Good afternoon.
Can you hear me?
Yes, it is audible for me.
Thank you. Dr. Girma, are you there?
Yes, Dr. Guta, I'm here.
Okay, thank you. We're going to start now.
Dr. Fekadu, please try to unmute yourself. Yes. Perfect. Now you can proceed.
Okay, good afternoon, everyone. We are happy to have you all as participants today. We are going to discuss the important topic on update on diagnosis and management of viral hepatitis. As you all know, viral hepatitis is common overall the world, including our country. So, because of this, sometimes it is called also silent pandemic. Silent pandemic, because people are unaware of their infection and they go untreated for years. The WHO's 2012 team is also says bringing hepatitis closer to patients, thinking that the importance of raising awareness about the need of simplifying and bringing the hepatitis care to primary health facilities. So, to discuss on this important topic, we have a guest or a speaker who is a hepatologist and a gastroenterologist as well as a hepatologist from Adam Hospital Medical College. We are happy for, we thank you, Dr. Fekadu, for joining us. We are happy for having you as a presenter today. So our participants, if you have any question, you can inbox us through the chat box, or you can raise your question at the end of the presentation. So over to you, Dr. Fekadu. Are you on, Dr. Fekadu?
Very important topic, very relevant to the community as well. So what I am going to address is some overview of viral hepatitis in general, and the more emphasis to the chronic viral hepatitis, especially Hep B and Hep C. So this is Adama Hospital, as maybe if somebody don't know, it's recently changed name to Adama Comprehensive Specialty Hospital Medical College. Working here for the last 3 years. So I have nothing to disclose. So these are my outlines. So as a journal, liver is one of the big organ, second to the skin, and a lot of close to thousands of functions per day. So there's also, as any other organ, subject to different kinds of insults. One of these is infection, and viral hepatitis are one of the common infections. These are 5 viruses named as A to G, especially the 5 viruses are very common. And, their name is actually given according to their identification. There are similar in manifestation, in which there are some differences. So as you know, A and E is said to cause acute process, acute hepatitis, and B in majority of the cases. So B and C, in the presence of B, G can also cause chronic liver disease. So the common cause of death actually lead to B and C, and deaths are actually to liver-related complication and hepatocellular carcinoma. So most of them have incubation period more than months, and almost all are RNA except B, which is DNA virus. And the mode of transmission is, as we know, A and E is fecal-oral, B is especially C is bloodborne, and any fluid can transmit B and D, and the vertical transmission is for sexual, and the vertical transmission for B. C and D actually vertical transmission are not as very common.
Excuse me, Dr. Fekadu.
Yes.
So, sorry for interrupting you.
Yes, yes.
Hello? Hello?
Dr. Guta, please try to unmute yourself.
Yes.
Dr. Guta, we are not hearing you, please.
Dr. Damanu, can you hear now? Hello, Dr. Damanu. Hello, Dr. Damanu. Can you hear now?
Yes, Dr. Guta. It's well heard.
All right. So,
Yeah.
continue.
Again, unmute your. Okay. So shall I continue?
Yes, continue, Doc.
All right.
Yes, continue.
Sorry for the inconvenience. So, I was talking about some comparisons. So the mode of transmission, as already said, for B and the D, it's more of body fluid. Sexual as well is very common. Vertical transmission is not very common for D and the C. C is usually bloodborne virus. So chronicity, as you know, the B, C, and the D can cause chronicity. A is also related, especially. I think there are some echo. Hello? Hello?
Hello, Dr. Fekadu. We are hearing you.
Yes.
يسمى
Hello, hello.
Others, please unmute yourself.
Hello,
Hello, Dr.
are you hearing me?
Yes.
Shall I continue?
Yeah, continue. We are unmuting others.
Yeah, there are some echo, that's why I stopped.
Yeah, we are unmuting them.
Sorry for the inconvenience. So let me summarize the hepatitis A. So it's RNA virus has already introduced the transmission is fecal-oral, related to sanitation, hygiene, and so on. Rarely transmitted through blood exposure as well. And majority of the cases are young adults, like teenagers and early 20s, are susceptible. So most of them are actually symptomatic, unlike children, where most of the children are more than 90% are asymptomatic. There's no report of chronicity. Sometimes can go to fulminant course, especially in immune-compromised individuals, those who have also underlying chronic liver disease of other causes. Otherwise, most of the time it is self-limiting. So this is after infection, which after a short period of incubation period, usually 2 weeks, patient can start to shed, maybe start to have viremia, then shed in stone. The manifestation then develops. So IgM is very important diagnostic marker that lately the IgG can also after some week. So IgG is the protective long term. Patient with who have developed IgG actually is protection and will never have the disease again. So as already said, it's preventable. Improving the hygiene is very important in our setup. The 2 doses of vaccine are effective vaccine after 2 doses, almost 100% protect. And the other ways in our setup is especially improving hygiene, sanitation, and set are very important. Cost effectiveness in our setup is questionable. In vaccination is questionable because what it says that around 90% of our children at the age of 10 actually have the serology detectable for hepatitis A. So vaccinating this individual, as I don't think it's cost effective. E has similar mechanism of mode of transmission, but more severe disease and a slightly longer course, and sometimes can cause acute liver failure, especially in pregnant. It is more common in the developing countries, especially Southeast Asians and Africans as well. It has some epidemiological patterns, clinical manifestation, somehow related to the genotype. Around 7 genotypes is said to be identified. More common is 4 genotypes. Genotype 1 and 2 are associated with epidemic, sometimes sporadic diseases, and especially it can cause acute liver failure in pregnant ladies in the late trimester of pregnancy, and it is transmission is human to human. There is no report of chronicity for genotype 1 and 2. Genotype 3 is more commonly in developed world. Actually, it can also occur in developing world. So it is the last decades, it's identified that genotype 3 especially can cause chronic liver disease, including cirrhosis, and especially among immune compromised individuals, like individuals with having transplantation, like kidney transplantation, for example, is practical in our setup. Those who have HIV or immune compromised due to chemotherapy and so on, this can have chronic course. So the teaching is hepatitis E can cause acute hepatitis, but there are some issue, especially genotype 3 and a report from genotype 4 as well, can cause chronic course. This is what I have already said. So if an individual, immune compromised individual, had persistent elevation of liver enzyme for a longer period of time, we have to have high index of suspicion, so that if you identify this virus, the treatment is ribavirin and interferon, and the effect is modest one. Otherwise, it can cause fulminant hepatitis actually. So when compared to the others, if superimposed with other liver disease, it is the commonest cause of fulminant liver failure in the death. Otherwise, treatment is supportive for especially genotype 1 and 2 that cause epidemic. Vaccine is not approved, but in Asia, especially from China, there is available vaccine which is FDA approved. So that vaccine has modest protection, so it's being given in Chinese. Otherwise, it's not FDA approved. For genotype 3, especially with chronic liver disease, hello?
Sorry, now you can continue. Someone unmute his mic.
Yeah, thank you. So, especially genotype 3, which can have chronic course, we can also give them ribavirin, and is for 3 to 6 months, 2/3 of individuals actually responded to therapy. So coming to the major topic, which is chronic viral hepatitis, which is very common in our setup and one of the killer actually in our setup. So especially for B, 1/3 of population, worldwide population is said to be exposed. That means the core antibody is positive. It doesn't mean that everybody has infection now. According to the WHO 2020, over 300 million individuals have this infection, the combination of B and C, and nearly 1 million deaths from B. And of course, only few individuals actually know their status. Despite this, the vaccination program, only worldwide, only 42% of globally took birth dose vaccine. That means defined as vaccination of newborn in the first 24 hours. So it's the cause of disease, leading cause of liver disease worldwide, and every year around over 1.5 million cause of chronic hepatitis, both B and C. And also said to be silent killer. The common cause of death is related to liver cancer and cirrhosis associated complications. When it comes to our setup in our country, the combination is said to be the cause for nearly 2/3 of cause of liver disease, including cirrhosis and chronic hepatitis, and 80% of liver cancer are also associated with B and C. And the recent report also in 2021 have shown that the 3 top common cause of liver disease is said to be B and C, and followed by alcohol. So it's a major problem in our setup. According to the WHO reports, annual mortality in 2000, when compared to 2000 and 2015, the common infections that are associated with disease are like malaria is dropping, as you see, malaria dropping. When I was in medical school, the majority of the ward are occupied with malaria, severe complicated malaria and HIV. Now, rarely patients admitted, especially in our setup. And also tuberculosis is dropping, but still yet tuberculosis is still a major problem. and HIV is now also dropping. When you see the viral hepatitis, the cause of death is increasing. It's said to be surpassed all the infections, and in African setup also the same is true. And when we see 2019 and 2013, viral hepatitis was the still the common cause of death in early 90s, but then around 8 years back, it is the 7th, even higher than HIV, higher than tuberculosis and malaria. So still with this annual mortality, it is neglected disease. So majority, if you see the fund, the money expenditure for some other infection is by far, it's almost for HEP it's negligible. And but now since 2016, there is global attention. WHO has already declared for decreasing the new infection by 90, eradicating the viruses, and the set goal more hope. So it has now getting attention in Africa. Africa is not safe as well. Nearly 70 million of infections in Africa. 90% is from HEP. So nearly 200 diseases each year in Africa, more killers than HIV, malaria, and tuberculosis. So when it comes to the B, it's the DNA virus already. It's very small, circular, cover the genetic material. The DNA is covered by 2 layers: the envelope outer layer, on which the surface antigen is available, and the capsid, which is a protein code that covers the genetic material. It is partially double-stranded DNA with polymerase inside. So it has 4 overlapping genes, the S genes that code for different surface antigen, the largest gene, which is the P gene, which code for polymerase, and the X gene, as well as the C gene that translated into the envelope and the core protein. Different genotypes. Actually, these days, the genotype during the era of NUCs, genotype is not a big issue, but in the interferon days, you know, genotyping is very important because some respond to genotype for interferon. For example, A and B are actually very effective, can effectively treated with interferon, and the D was resistant. And genotype 3 is said to be associated with more severe diseases like disease progression to cirrhosis and the risk of HCC, at least among Asians. So C is more aggressive when compared to the other. Otherwise, genotyping is now it's not a big issue. Coming to the life cycle, this virus is DNA which is envelope covered. So it attached to the hepatocyte. It's very highly hepatotrophic. So it uses the sodium transport, the bile acid transporter. It attaches through the PS1 to this receptor, and endocytosis by the hepatocyte. After entering, you know, there is release of the capsid with genetic material, which is transported into the nucleus of the hepatocyte. In the nucleus, this is what we have already said, that this is a DNA virus with partially closed and relaxed actually. Then this relaxed DNA should be repaired actually. So it is being repaired inside the nucleus with say to be the host enzymes are majorly involved. So once it's repaired, it forms the covalently closed circular DNA, which is very stable and very important actually. Because of this is stable part of the life cycle. It's actually no drug is acting on this. One of the cause of persistent infection is because of the stability of the cccDNA. So this is cccDNA is a kind of mini chromosome, so that it uses this DNA as a template for transcription for different viral RNAs, including the bigger RNA, which is the pregenomic RNA, and the other subgenomic RNAs. So this pregenomic actually, all the RNAs actually exported into the cytoplasm, in the cytoplasm, the pregenomic RNA with the polymerase and the core protein, there is encapsulation, a kind of layer formation that covers the genetic material. So there is an encapsulation process. This encapsulated pregenomic RNA actually reversely transcribed for negative strand DNA. So this is a site where our now currently available drugs are acting. And with the same enzyme, it also transcribes the negative to the positive DNA. Once the positive strand DNA is formed, now it's a partially closed, it's a double strand partially closed DNA. So there are two phases. One is it is assembled with the help of other incorporating to other proteins and released as Dan particle or the viron, or the other way is it again replenish and constantly, transported to the nucleus and to augment the already cccDNA to form or to increase the pool of the cccDNA in the nucleus. So it is a persistent infection because of this. And the other peculiarity of Hep B is very complex, and the other form is integrated into the host genome. And the other peculiarity is there are viral proteins that are released from the hepatocyte without having genetic material. Only the surface antigen in the envelope antigen, especially the surface antigen, is very, very huge, almost 10,000 when compared to the viral. So this release of surface antigen is said to be exhausting our immunity. This is a method of escaping our immune clearance. So what the reason of actually persistent is, one is stable cccDNA, two is because of integration, three is because of majority of the protein are released with even a great amount and exhausting the immunity. Okay, and epidemiologically, the developing countries, especially Africa's in general, either highly endemic or intermediate endemic. So Ethiopia is among prevalence more than 8%, and the South Asians as well are highly prevalent areas. So in the highly epidemic or endemic areas, the lifetime risk of infection is around 8%. So everybody is susceptible in our setup. Coming to Ethiopia, there was study, actually it's seroprevalence and a national-wide study from stored sample, including more than close to 8,000 individuals. And the seroprevalence, according to the study, is almost recent one is 9.4. That means 1 out of 10 individual is actually surface antigen carrier. So it's highly prevalent, and the antibody toward the surface prevalence is higher in male. And this infection is actually doesn't matter what setting it is, whether you are married or divorced or single, whether you are rich or poor, whether you are educated or not, and any setting, you are all susceptible. So when it comes to the region, Afar is actually the highest prevalent, almost 29, close to 29, 1 in 3 individuals actually infected. Gambela is around 13%, Oromia is 10%, close to 11%. So it's highly prevalent everywhere. And study from St. Paul has shown that majority of individuals are actually E negative, Hep B. So the E antigen is negative in almost 91%. And the genotype are A and D are the most prevalent. Transmission is very important. The mode of transmission. So both horizontal and the vertical transmission is very important in our setup. In the Asian continent, the vertical transmission is very common. But even in our setup, that's also very important mode of transmission. Otherwise, studies have shown that in our setup, especially in Ethiopia, because of there are low variant individual, high percent of E negative individual, maybe vertical transmission may not be as great, but individual children actually get this infection after born, especially in under 5 from their elder child, from mother and son. Otherwise, it is any fluid can transmit, including even saliva, urine, even if the prevalence is, the risk is lower when compared to the blood, percutaneous injection, the local factors like tattooing, scarification, and very important, it is said to be 100 times more infectious than HIV and 10 times more infectious than Hep C. This is a study which I talked about. A study from Tanzania has shown that horizontal transmission is very prevalent. They compare mothers who have hepatitis B versus mother who doesn't have surface antigen positive. So at 8 months, almost nearly 8% of infants actually have infection surface antigen positive. Even the same study has shown that after 18 months, this prevalence, this number increased to nearly 30. More after infection, actually infection is very common even after delivery. So I hope we have started vaccination since last 7 or 8 years. I think since 2007, this prevalence will drop. I hope if you have effective and strong EPI program. This is the same is true. Some studies have shown that under 1 children is surface prevalence 3%, but adult, as you know, is as high as 9%. That's already. So the age of exposure is very important. So if an infant exposed during delivery, the chance of getting chronic viral hepatitis is around 90%. So every exposed, it looks like that every exposed infant will develop chronic Hep B. And of course, even under 5, the risk of developing chronic liver disease is as high as 50%. So we need to prevent that. Who should be screened? So who should be screened? According to the international guideline, every individual from Africa should be screened. We are actually over the hyperendemic area, so I think all individuals coming to health institution should be screened. Otherwise, we cannot screen all because we are over 100 million. So we have to give priority, especially those individuals who born from Hep B positive mothers should be screened. Should be given priority. Healthcare individuals, those who are co-infection HIV, Hep C, those who have abnormal sexual behavior, polygamy especially, actually before the chemotherapy. If you are planning for chemotherapy, we should screen this individual before we initiate. Local practices are also very important. This part like tattooing, scarification, individual actually burns their abdomen or chest because of feeling some kind of pain to their abdomen, and they actually burn their skin. Maybe that could be also be one of the risks. Tonsillectomy, circumcision is found to be local risk factor. Of course, any abnormal liver enzyme screening should be done. So the method of screening, what we use for screening is also very important. Actually, what's recommended is screening should include surface antigen and core antibody. And not only that, you have to also assess whether the individual has immune or not. So these triple serology markers are said to be important for screening. So once we screen, we need to interpret. So if somebody has surface antigen positive, means it's a marker of infection. So if the surface antigen is positive, it means that you are infected. Whether it could be an acute or chronic. Surface antigen is a marker of infection. Core antibody is a marker of exposure. That means you have exposed in the past, especially if your IgG is positive. If IgM is a subclass that identified, it's the exposure is recent. So it doesn't mean you are infected, but there is an exposure. And antibody to surface means you are immune, maybe through vaccination or could be through previous infection. So if an individual has surface antigen positive and the core antibody positive, especially the IgM, it means an acute infection. Sometimes they can have E antigen. So the presence of E antigen means highly infectious. So E antigen is a marker of replication, and it's a marker of highly infectivity. If somebody has surface antigen positive or antibody positive, it's exposed and infected. If the IG class is subclass is positive, that means it's a chronic. So that if it has E antigen positive, means it's highly infectious. If somebody has surface antigen only positive, the others are negative, that means he got immunity or is immune because of immunization. But if the core is positive, he is immune because of the previous infection. And the surface antigen is negative, means he is recovered from infection. But there could be some reactivation. So the natural course is once they develop, we have already said that as adults, if there is an infection occur, almost 5 to 10% can develop chronic infection. Once they develop chronic infection, nearly after 5 years, nearly 30% can develop cirrhosis. So once they develop cirrhosis, they are at risk of liver cancer and at risk of liver failure as well. Nearly 20% develop liver failure after 5 years. So the peculiarity of Hep B is they can develop liver cancer even without cirrhosis directly from chronic infection. Unlike Hepatitis C virus, where liver cancer developed from cirrhosis, Hep B can directly cause, because it's oncogenic, because of the integration and because of the Hep B protein X, which is carcinogenesis. It can modulate carcinogenesis. That means the patient can develop liver cancer. That's actually we are observing young 20, 30 years old coming with hepatocellular carcinoma, even without developing cirrhosis. This is very rare. So once you develop the patient develop liver failure or liver cancer, the risk of death is high unless liver transplantation occurs. But there are factors that can increase the progression. So it's not, this progression is not common and the same for all individuals. There are biological viral markers, factors or host factors that increase the progression to cirrhosis or liver cancer. Like older individuals, families of liver cancer, these are individuals that we should catch actually, and the lower tendency to treat. Male are more risky than female. The presence of fibrosis or cirrhosis also makes the increase the risk of liver cancer. Those who are consume alcohol while having Hep B, also the risk of progression is very high. Or biological markers, if DNA is important. So this is identified with REVEAL study, which you will see. So DNA more than 2,000 international units is risky for progression as well as for development of liver cancer. So E antigen status is also very important. Genotype C is risky because the risk of progression is faster, and E antigen conversion is lower for genotype C. So liver enzyme elevation is also another important. This is the study maybe recently has shown that as liver enzyme increases, the all mortality, liver-related mortality as well as liver hepatocellular carcinoma or decompensation increase as the liver enzyme for both sex, male and female. For female, even lower than around the mid of 20 could be a risk. For male, actually beyond 40, the middle of 30 of ALT can be risky, especially after 40 upper limits, the progression is very fast. Other important is, once they develop chronic infection, there are phases, especially this is very common in the vertical transmission, especially in Asian continent, where vertical transmission is very common. Once the patient has got an infection, there is a long latency period, the so-called immune tolerance phase, where our immunity is not attacking the virus. So the virus is keep replicating, so that most of these individuals, actually younger individuals and early 20s, teenagers, and so on, having very high viral load in millions, but ALT is normal. So normal ALT, high viral load, high surface antigen level, and biopsy actually shown there's no marked inflammation or minimal or no inflammation. This is a normal. So majority of this individual actually doesn't need treatment. But because of unknown reason, our immunity start to recognize the virus and start to attack the virus after a decade, probably. Then once the immunity recognizes that there is a fight, the space of liver, so there is elevation of liver enzymes, typically elevate, but sometimes fluctuate. The viral load start to decline. Still, there are e antigen positive, and the surface antigen start to drop. And actually, these are individuals very risky for progression to liver disease, liver cancer, or cirrhosis. So the longer period the patient stay in this phase means the high risk of progression. So this individual actually needs treatment. And if our immunity win the virus and try to control it, the DNA continue to drop, actually less than 2000, usually low viremic, and the surface antigen levels also usually decreases. ALT normalized because already it's controlled. This is the so-called carriers. Now there is conversion of e antigen to e antigen, develop antibody to the e antigen. There is zero conversion, so risk of infectivity. Majority of these individuals actually are older and doesn't need treatment in most of the cases. But sometimes, especially older individuals beyond age of 40, those who have taken immune suppressive agents or chemotherapy and so on, there could be reactivation. So reactivation can happen. That means the liver enzyme again suddenly raise to upper normal or to probably elevated, and there is increment in viral load. So this individual again, needs treatment. Unless we treat this individual, the chance of deterioration or progression to cirrhosis or to decompensation is very high, and the risk of H is also very high. So the EASL actually has they developed the Society of European Society of Liver Disease has developed new classification, because the immune tolerance is a misnomer. Sometimes patients can have a higher risk of death. The carrier also is a misnomer, because this individual is still at the risk. Because of that, there is a new classification as based on e antigen positive or negative. They actually do e antigen status for every patient visits their clinic. That is not practical in our setup, because one thing is costly one, the other is not regularly available. Because of that, actually e antigen is not routinely done in our setup. Otherwise, it can classify. Based on that e antigen status, they consider as e antigen e antigen positive or e antigen negative, and depend on the ALT level, or maybe if they do biopsy, based on the biopsy level, they classify as whether an infection or hepatitis. If the individual has raised ALT, still e antigen positive, this is hepatitis, already have the disease, not an infection. So infection is ALT is normal, the so-called immune tolerance phase, where the individual has millions of viral load, but ALT normal, e antigen positive. They call e antigen positive chronic HB infection, not hepatitis. So this individual actually doesn't need treatment. And if an individual has still had normal ALT, lower viral load, e antigen negative, still an infection, which is e antigen negative, so-called carriers. Otherwise, e antigen chronic hepatitis could be antigen positive or antigen negative with elevated liver enzymes. These are easy to classify individuals, but actually we are not routinely do e antigen status. So once you identify chronic HB, you have to assess because the need of treatment is very important. We have to assess for any cirrhosis. Whom are going to how long we are going to readiness for treatment, and assessing for risk of hepatocellular carcinoma is also very important. So there are some parameters, especially liver enzyme, liver function test, ultrasound, non-invasive marker like fibroscan, assess the severity and degree of fibrosis, CBC, especially assessing the APRI score, evidence of portal hypertension, possible antigen status can classify further. Your infection, the infection status, and the end game. So this is non-invasive. The non-invasive status, the FIB-4 and the APRI score are the widely used. Some experts prefer to use the FIB-4 because it includes age, where age is very important. Anything more than 3.5 means the patient has moderate to severe fibrosis. APRI score is in our setup where actually 1.5 is related to or associated with advanced fibrosis. More than 2 is identified individual with cirrhosis, very specific, or if you use 2 points. But now with this criteria, majority of this is the WHO criteria actually, majority of individuals actually missed. This is study, local study from St. Paul by our colleagues, Dr. Hanna and my mentor, Dr. Haile Michael, have shown that if you stick to WHO guideline with this criteria, nearly close to 50% will miss treatment. And there is a so-called St. Paul criteria where those individuals having 0.7 of APRI score should be started on treatment. And currently, we have one of the center of hepatitis in Adama Hospital, where one of the criteria is 0.7 of APRI score. Otherwise, if you have FibroScan, it's also available in some of the big cities, in Nargis, in Moderator, in St. Paul, it's available. And if you have FibroScan, it's actually slightly better sensitivity and specificity in identifying significant fibrosis and cirrhosis. So that's also very helpful. Then, if you decide to manage this individual, especially with significant fibrosis or cirrhosis or having evidence of liver injury, with that means elevated liver enzyme, then we have to manage, we have to put on medication. But what are our goals while we are putting this individual in drug treatment or therapeutic drugs? So our goal is achieving, normal ALT and suppressing the viral load and actually changing from the so-called chronic hepatitis to chronic infection. By doing that means you are reducing, the risk of HCC, preventing cirrhosis, improving survival in general. And the other, of course, recent goal is, if possible, surface antigen loss is the end point in the current treatment. But actually that is very far from reality, but majority of our individuals actually who are very adherent to medication can achieve this one. Normal ALT, e-antigen seroconversion, and suppressed viral load is possible in most majority of our individuals we will see. So who should be treated? Is also one of the important. Yes, all cirrhotic individuals should be treated irrespective of viral load and ALT. And all individuals with APRI score more than 2, regardless of the e-antigen status or ALT, should be treated. This also our guidelines support that. But the other individuals are actually depends on whether they have liver injury or high viral load, or the combination is very important. So it's differ among the guidelines. Some, especially the e-antigen status, there are international guidelines depend on the e-antigen status, the level of ALT. The normal is also somehow variable across the guideline. But anyways, if the individual is e-antigen negative, or across the old guideline, there's a cut point of 2,000 viral load. International unit is the cut point for all. Our guideline also consider whether the patient is e-antigen positive or negative, 2,000 is the cut point. If the patient is e-antigen positive, the AZ is still considered 2,000 as the cut point, but the other like ASLED consider more than 20,000. So the upper limit is also one of the factors differ among the guidelines, but usually use 40. The same is true for EASL. So this is the Ethiopian guidelines. It's a draft. Actually, it's now published, and on the way to be distributed this year. So according to our guideline, any individual who are cirrhotic should be, whether that is compensated or decompensated, should be treated, or those individuals having APRI score of 2 and detectable viral DNA should be treated. Those individuals younger than 30 having ALT, persistently elevated ALT previously, but now even a single measurement of ALT more than 40 plus high viral load it should be treated. But younger individuals, actually rest liver enzymes, persistent one with 20,000 cut point is one of the indication of treatment. Those who are having HCC and high viremic should be treated as well. Of course, if there is co-infection, one of the indications for treatment. So why DNA of 2000 is considered as cut points? So this is a study from Taiwan, actually included a lot of patients. And what they identified is they followed their patients over decades, actually for a longer period of time. Then what the most important factor which are associated with incidence of HCC was the level of viral load. So at viral load of 2000 international unit or 10,000 copies, you know, the incidence of the HCC start to increase. So that's why considering the viral load of, that is independent of actually the age, other factors, ALT level, and both cirrhotic and non-cirrhotic. So the viral load of 2000 is very important as cut points based on this finding. And the other thing is not only the incidence of HCC, even liver-related mortality has increased, start to increase. The curve separates, actually the line separates, starting from viral load of more than 10,000. 10,000 means this is copies, but when converting to international units, around 2,000 international units. So anything more than 2,000 international units means liver-related mortality as well as incidence of HCC will increase. That's why we consider that. But is less than 2,000 safe? This is also has shown that individual who have less than 2,000, usually, especially individual E antigen negative, the level of surface quantification of surface antigen level is very important. So if you identify surface antigen quantification, and if those individuals having more than thousands of surface antigen level, means still the risk of death, especially HCC, is very high among cirrhotic. So not always 2,000 international per ml is safe. So the importance of is it important to treat is very important. This study from Hong Kong has shown that those who maintained viral suppression and detectable viral load with treatment, the survival is improved. Liver-related mortality decreased, and all-cause mortality also suppressed, or for those individuals who have achieved and they maintain viral suppression. So treatment is very, very advantageous. Then what are the treatments that we have now? In the early 90s, it was the treatment is only from standard interferon, but around late 90s, lamivudine came to market, and then adenofovir in 2005, the pegylated interferon, and then the entecavir started approved in 2016. Now we have talvivudine, tenofovir, and TAF in 2016. So we have a lot of drugs, but which of these drugs is actually approved is we are going to see. So the approved one is the entecavir, TAF, and tenofovir derivative. Both TAF and the TDF is approved now because of high potency and high genetic barrier, but these are already failed. Lamivudine is being used early, but now it's out of favor now because of the high resistance. After a year, the risk of resistance is around 25%. After 5 years, almost 75% of individuals will lose lamivudine. So adenofovir is the same. Talvivudine, sometimes we use in pregnant ladies, for a short period of time. Otherwise, it's out of favor now. So when you see tenofovir, the dosing is, as you know, is 300 milligram per day. It has shown that, you know, this is a very important study. Have scores based on the degree of fibrosis. So those who have score of 6 and 5 means the patient has advanced fibrosis or cirrhosis. So after initiation of tenofovir or TDF, when this individual after 5 years, you know, cirrhosis has regressed. Cirrhosis has regressed, fibrosis has regressed, and there is an increment of the low-grade fibrosis. So that in the old days, cirrhosis is irreversible, but nowadays it has shown that there is some degree, especially early cirrhosis, reversible, because as you see, after 5 years, the cirrhosis is shrinkage. There is improvement of this line that shows low-grade fibrosis improved, and advanced fibrosis, especially FP3, has regressed. So tenofovir is very important. Of course, not only tenofovir, entecavir as well is very important in the management of spread. Entecavir is also very valuable, but make sure that your patients are already exposed to lamivudine. Because there is cross-reactivity, nearly 50% lose effect if they have resistant to lamivudine before. Tenofovir alafenamide or TAF is, as we know, it's one of the drugs that is approved for HIV as well, with lower doses for Hep B, 25 milligram per day. It's the derivative of TDF, and with this low dose, you know, it has similar antiviral activity, less systemic exposure, so that the side profile is more important, very safe when compared to TDF. Otherwise, it's equally functional. So the concentration into the hepatocyte is very high. That's why lower dose is being used. So this is a very important study, have shown that long-term entecavir as well as TDF has shown that there is the degree of viral suppression is very marked. Almost after 5 years, almost all has both antigen positive or long-term NUCs has better advantage. We have already said that virus suppression, maintaining virus suppression is actually has got mortality benefit. The same is true in the real world. This is a study from different parts of the world where use of entecavir or TAF has improved or suppressed the virus. This is after 3 years, but you know, surface antigen loss is almost minimal, surface antigen almost negligible. Otherwise, it has the suppression of viral loss as achieved with TDF or entecavir. So this is a study to compare between TAF and the TDF. It's an inferiority study, so that TAF is not inferior to TDF in degree of virus suppression, both E antigen and E antigen positive and negative. So it's equally effective in suppressing the virus, but the side effect profile is almost better with TAF. And the other is, shall we discontinue once we started, is also one of the important, and now it's one of the controversial issue. So do you stop after initiation of NUCs is always a question the patient usually asks us. This is a very beautiful study from Greek, actually, have shown that included 25 studies, the system meta-analysis, showing that after 36 weeks, months, or after 3 years, almost nearly 50% of patients have virological reactivation, high viral load, and ALT elevation and so on. So only 52 individuals actually have sustained viral remission after 3 years after discontinuation. So there is high. This is all in E antigen positive individuals. For E antigen negative individuals, almost after 3 years, only 30%, almost 70% of them actually have increased ALT virus. The virus are no more suppressed. So there is increment of relapse of disease activity after 3 years for E antigen negative. So because of this, what is said that it is very risky to discontinue after initiation of NUCs. what the guideline says. So the most of the influential guidelines, the EASL and ASLED, what they suggest is if your patient is cirrhotic, there's no guidelines that recommend discontinuation. So don't discontinue if your patient is cirrhotic unless there is chance of surface antigen loss, which is very rare in individual with cirrhosis. If the individual have surface loss, yes, you might try. Otherwise, it's not recommended to discontinue. What about E antigen negative? The ASLED suggests against discontinuing, especially in E antigen negative. But the EASL, what they say is probably you might try if your patient, after 3 years of treatment of viral suppression, if your patient is actually close monitoring is feasible. If you are following your patient closely, like every month and so on, you might try, but very, very risky one, where follow-up in our individual, in our population actually is not, we cannot say close follow-up, because sometimes they come after 4 months, 6 months, and so on. So it's not feasible in our setup. But for E antigen positive, maybe you might try after individual has seroconversion of E antigen, for E antigen positive to E antigen negative, both guideline recommend this. And if the individual has ALT normalization or biopsy shows that there is no inflammation, in that case, you might consider after 1 year of augmentation treatment. So when do you expect this seroconversion is variable, but the majority of studies have shown that like maybe it takes like 3 to 5 years for this viral E antigen seroconversion or normalization of ALT and so on. After you identify suppression of viruses plus E antigen seroconversion and normalization of ALT, you can monitor for 1 year. If there is actually the individual stage with this scenario, you might try to discontinue. Of course, if there is surface antigen loss, there is no way you can discontinue. So, but this is far from reality. So, is it possibility of cure from Hep B? Is it possible? Actually, studies have shown that this is the virus can be found in both in the serum and in the liver. So, cure is defined actually different definition of cure. Even if still definition it varies according maybe most of expertise they call it partial cure if an individual have virus suppression, normalization of ALT, and E antigen seroconversion. That is partial cure, where majority of our individual achieve that. But this individual with partial cure actually still they have surface antigen in their body. The surface antigen is still there. But the so-called functional cure, where currently the scientific community actually working to increase the chance of functional cure. Functional cure is defined as where an individual lost their surface antigen and detectable viral DNA, but still in the liver there is integrated as well as cccDNA. So there is surface antigen loss with virus suppression, E antigen conversion, and so on. So after 5 to 8 years of NUC therapy, actually only 5% of individuals actually lost their surface. So the researchers are actually doing on working on this to increase the chance of functional cure. Complete cure is still surface, there is surface antigen loss, and still, but DNA is also lost. The cccDNA is lost from the liver, from the hepatocyte. So we call it complete cure. This is very far from reality. Sterilization cure is means similar to non-infected individual, where also integrated DNA is lost. This is by far almost remote, but I think maybe possible in the future. So scientists are working, the research communities are working to get rid of this virus, at least suppressing the surface antigen, increasing the surface antigen loss. The different in the life cycle of the virus, different mechanisms of action are actually targeting different mechanisms, like entry inhibitor, that blocking the bile acid transporter where the viral entry is blocked. This is true for hepatitis D virus as well. There are drugs that are silencing the cccDNA or disintegrating the cccDNA. There are drugs acting on the encapsulation, blocking the capsid formation. There are drugs that interfere with the messenger RNA because these RNAs are transcribed from the cccDNA. There are drugs that are blocking that. Of course, we have NUC that are actually working on the reverse transcription. And there are drugs actually that are working on release of surface antigen, the release inhibitors. There are drugs that are working on our immunity, augmenting our immunity, and there are also, of course, vaccinations. There are around 50, more than 50 trials on different phases. Hopefully, in the coming 5 or 10 years, maybe possibility of surface antigen loss is, I think, is possible. That's my hope. Maybe I can comment on D. It's a Delta virus, effective, uses a surface antigen of Hep B for in the life cycle for application, and it's a kind of pocket incidence across the developing country in Africa, especially in the Western Africa as well. And there is 2 scenarios: co-infection and the superinfection. Co-infection is where, because of the similar route of transmission, an individual can get B and T at the same time, and this individual actually develop permanent hepatic failure or permanent disease, but majority may clear Hep B, especially then if you clear Hep B, that means D is also clear. The problem is with the superinfection. This is a chronic Hep B individuals infected, either carrier or maybe activities on which patients have acquired hepatitis D virus. Majority, nearly 90% of them actually develop chronic severe liver disease. That important virus is the C. This is a RNA virus, enveloped. Actually, it is RNA virus, single-stranded positive sense RNA virus, highly replicated viruses, and it is actually new infection is almost nearly 1.5 million per year, as already said. Different around 6 genotypes worldwide. There is no vaccine because of high variability and different mutation. Because of that, vaccine is not possible, but 90% of the case it's curable. So to say something about the life cycle, most of the life cycle in this virus is actually take place in the cytoplasm. Actually, entries into the hepatocyte is its senses is covered by lipoprotein, and it senses the hepatocyte actually internalizes any lipoprotein covering agents. So because it uses that, so it is communicated with some receptor or proteins on the hepatocyte. Once internalized, encoding takes place, and all the replication takes place in the cytoplasm. There is no integration. There is no nucleus involvement. That's why it is easier to treat this virus. So, as already said, because of high replicative nature of the virus, there are different genotypes, especially 6 genotypes, which differ in 30% of their amino acids. So 6 genotypes, the common genotype in our setup is genotype 4, followed by 1, either isolated or mixed. So the different genotypes actually, the treatment option, they differ maybe, and the duration of treatment, somehow the outcome was slightly different. Otherwise, the mode of transmission is almost similar. And in our setup, as already said, majority of the genotypes is 4 and followed by 1. The seroprevalence currently not 1, it is said to be 3.4, even if the differ across the risk groups. So some say 1.4 from health professional, health volunteers, blood bank. There was prevalence was 0.6 in the old, but currently 3.4 in the community-based surveillance. So transmission is percutaneous most of the time, the bloodborne. locally specialist clarifications, the already said multiple and tattooing and so on are very risky one. Otherwise, transfusion could be, especially if we fail screening set individuals. Mother to child transmission is almost not common, but in those with HIV, it's as high as 20% of the cases. So who are at risk? So people with HIV, patients on hemodialysis, patients who are on blood transfusion without screening, health professionals are also risky ones. So we need to screen. So the natural course. So the natural course in most of the time is as high as 85% of the cases. It's a chronic process. Otherwise, 15% can resolve after acute viral hepatitis, even if majority of the acute viral hepatitis are asymptomatic. Sometimes as high as 50%, some say up to 45% can clear the virus. So once they develop process, it takes a long period of time to develop cirrhosis and its complication. But those individuals who have confection with heavy HIV or alcoholic individuals, those who have overweight and so on, the progression can be fast. So there are factors that can modulate the progression. Genotype 3 is more aggressive than the other genotypes. So in patients with acute infection, once they are symptomatic, our body will clear the virus. So the RNA is negative, but the antibody actually is long lasting. So in chronic, it's highly viremic and antibodies are still exist, and the patient are actually fluctuating ALT/AST. So how do you approach patient with once you screen? The screening method is actually the antibody test. So antibody test is the screening method. It's the first line. Once antibody is positive or negative, if it is negative, there is no way to continue. But if it is positive, then we have to confirm. So we should not disclose only from antibody test. So antibody test is positive means either the patient could be false positive, or the patient is already cleared, or the patient can have infection. So we have to confirm. How do you confirm? We have to do RNA test, either qualitative or quantitative. Usually we order. We also determine the viral load at the same time. Because of that, we are actually order quantitative test, but any detectable. If it is detectable, we have to, that means the patient has current infection, we have to link for therapy. If it is negative, that means either the patient will resolve it because the antibody is positive, or it's false positive from the antibody. So that is a two-step process that needs. Okay, then once antibody, virus, the RNA is detected, we have to work up for possibility of initiation of drug, because everybody should be treated. These are the things that we should do, like assessing for fibrosis, two-stage and so on. With CBC, platelets very important, as you know. APRI score should be, or FIFOR, if available. You can also use non-invasive fibrosis assessment, because liver biopsy is not actually being done in nowadays worldwide. So additional, we have to rule out pregnancy, we have to rule out co-infection. So these are the first line investigations that we should do. Then, who should be treated is very important. The guideline is everybody with viremia. So if RNA is detectable, everybody should be treated, unless there is a short life expectancy, like patient having cancer, whom you consider the risk of death is more high within 1 year, or patient with child class C, especially C more than 10, the risk of death could be very high. Still then, if the patient needs, maybe treating is possible. Unless you transplant, the risk of death is very high. The goal is to achieve SVR, sustained virological response. That means it's equivalent to cure or viral eradication. So when do you do that? You have to treat your case, usually most of the time, for 12 weeks. So it is after 12 weeks of the last dose that you should check for any SVR, for possible eradication. So with doing this, with achieving sustained virological response, we have to prevent complication, decrease HCC, improve survival, and improve quality of life as well. So achieving SVR, especially in the old days with interferon, has shown that transplant-free survival has improved, and the risk of HCC also decreased with the interferon era. All-cause liver-related and all-cause mortality as well improved with achieving SVR. The same is true with direct antiviral therapy, the current therapy. The risk of, once we achieve SVR, sustained virological response, the risk of all-cause mortality has reduced by nearly 80%, and the incidence of liver cancer has reduced by 85%. No more, it's not actually zero, but because patient might have cirrhosis and so on, usually to develop HCC, but significant reduction of HCC after treatment. This is evolution of treatment. So previously, standard interferon was tried, but with 6 months, the response was poor, and the extension of the duration, not much improvement. Addition of ribavirin, somehow 1/3 of individual has improved to achieve SVR. Then the extension of the duration is making it 42%. Then the pegylated interferon, nearly 40% with additional ribavirin, nearly half of individuals achieved SVR. Then in 2011, the direct antiviral comes to market, especially the first generation protease inhibitors. Was with this, actually, it was possible to reach SVR around 70%. Then around 2030, drugs like sofosbuvir will come to market, and 85% of individuals achieved. This was a big news for Hepatitis C community. Then in 2016, now we are in the interferon-free drug treatment for Hepatitis C virus. So these are the approved antiviral drugs. So these are actually, the virus has both structural and non-structural. The drugs are acting on the non-structural. These are the enzymatic part acting on the non-structural part. So there are protease inhibitors, there are replication complex inhibitors, so that this is very an important enzyme for wave forming where the replication takes place. So a lot of drugs actually acting on this and acting on the polymerase, especially the backbone of treatment is sofosbuvir. It acts on this. So they have different name prefixes. Actually, the protease inhibitors at the end with privir, all have privir. These are protease inhibitors. And NS5A inhibitors are aspir. So that's how you maybe remember. And buvir is for. Otherwise, you don't need to remember these all drugs. So now we are, interferon has gone, ribavirin still somehow can be used. The previously difficult population like HIV infected individual, blacks, genotype 3 and the cirrhotics are now still, they have good response, more than 95% of SVR, even the previously difficult ones. But the choice of drug depends on, you have to assess your patient before you initiate the treatment, like presence of cirrhosis, whether compensated or decompensated, whether cirrhosis is there or not. Previous history of exposure is very important. Renal dysfunction, you have to identify. Genotypes, nowadays, the issue of genotypes is almost not practical in majority of the world. Cost is also an issue. Then once you assess this, try to classify for possibility of simplified treatment. Simplified treatment is, the goal was to increase or expand the Hepatitis C care, because previously it was every individual with Hepatitis C infection were referred to the center with appearance, but now with this simplified protocol, we need to assess these individuals who are needed. So who are eligible for simplified way of treatment? Those who don't have cirrhosis, any genotype without cirrhosis and without previous treatment, these are individual group of individuals that are eligible for simplified. So just gives them pan-genotypic, like glecaprevir with bemnifosbuvir with 8 weeks, or sofosbuvir with valbata. This is available in our setup as well for 12 weeks. Or in our guideline also included is sofosbuvir with daclatazivir for 12 weeks as well, can be used as in simplified treatment. So who are not eligible for simplified treatment like this? Non-cirrhotic individuals, in patient with previous hepatitis C treatment history, this is should not be put under simplified treatment. So you should refer to the more experienced center. Cirrhotic individuals, especially decompensated one, the decompensated cirrhosis, co-infection, pregnant ladies, patient having period liver transplantation or suspect to have liver cancer. These should be referred to more experienced center. Otherwise, the other group we can use simplified and pan-genetic drugs can be ordered. So even for compensated cirrhosis, especially those individuals having, the fibrosis score like evidence of portal hypertension without child A classes, actually. Those who have child A class, we can use the simplified way of treatment, but child B and C or co-infected individual, pregnant ladies, liver cancer, if there is or suspected, these are also not eligible for simplified treatment. Even compensated cirrhosis, child class A can be managed as a simplified treatment with pan-genotypic drugs. So what are these drugs? Actually, for this compensated cirrhosis, we have different choices based on the genotype. Still, glecaprevir with previtazvir or GP can be used for 12 weeks. Actually, some studies have shown that 8 weeks is as effective as 12 weeks, but most of the guidelines actually recommend for 12 weeks. Otherwise, in other genotypes, we can use sofosbuvir valsartan as well. The problem with sofosbuvir valsartan is if by chance it is genotype 3, there is patient can fail somehow, but for other genotypes, we can also use sofosbuvir valsartan, so-called Eclipse. These are the genotype-based duration of treatment. In the previous days, Harvoni, which is available also in our setup for HIV negative individual, those who have low viremia, 8 weeks can be possible in genotype 1B. Otherwise, most of the time it's for 12 weeks for other non-cirrhotic individuals. So this also elbasvir grazo for genotype 1 and 4. 4 and 1 is more common in our setup, so it's an option, but it's not available. This is available, and maybe for failed individuals, these are not the first line, but for failed treatment, we can also use this triple therapy. So the pan-genotypic combination is, especially valsartan and sofosbuvir, is available in our setup. 12 weeks treatment is the SCVR rate is, as you see, 98, 99, 95, 100. So almost across the genotype, the response rate is, the cure rate is almost more than 95%. And the same is true for advanced cirrhosis. Even the response rate is very high, more than 95%. GP as well. For individuals with a treatment name or experienced, 8 weeks is almost similar to 12 weeks. For non-cirrhotic individual, even for compensated cirrhosis, is similar. But what the current recommendation is for non-cirrhotic, you can use for 8 weeks, for cirrhotic for 12 weeks. So SPR is almost 100 or more than 95 in majority of the cases. So the other thing is, if your patient has actually make sure that drugs are the patient is taking is very important, because these drugs are sometimes like antiplatelet drugs, or patient amiodarone for sofosbuvir-based therapy, or PPIs, for example, can influence so drug-drug interaction should be seen. Otherwise, they are relatively safe, and we can widely use this drug, and they're very effective. If your patients are having cirrhosis, we have to survey, especially after completion. We should not send them home. Every 6 months, there should be surveillance with ultrasound. Otherwise, once you achieve SVR after last dose of 12 weeks after last dose of treatment, if the patient is non-cirrhotic, you can advise to decrease the risk of reinfection, and you can send some home. This is a summary, and this is what I have. Thank you.
Thank you very much, Dr. Fekadu, for the nice and detailed presentation on viral hepatitis. I hope our participants have enjoyed the presentation. In this presentation, we had nurses, health officers, GPs, public health specialists, residents, internists, gynecologists, and also we had anesthesiologists. So we thank you all the participants and Dr. Fekadu. If you have any question, the participants, if you have any question, you can raise your hand. And, Dr. Fekadu will entertain your questions.
So,
Anyone? Okay, Dr. Gurmessa.
thank you all for attending such insightful presentations. And those who want to ask questions or suggestions, you can raise hands and unmute yourselves and proceed with your questions. Thank you.
Gazan, you can continue. Is that by mistake? Okay, anyone else? Dr.
Am I
Modi?
audible? Yep. Am I audible?
Yes.
Okay, so let me first, I want to proceed by sorry, moderator, Dr. Moderator. I want to comment. It was like a good presentation, and I hope every participant have learned a lot from it. The other thing is, it would have been much better if the presenter have in detail told us on the treatment part of the HPV, special HPV infection, which drugs are safer during the pregnancy period. Currently, I'm residing in an area where the HPV infection is like in a high rate because of the fecal-oral transmission and low prevention work that has been done by the other staff. So it would have been a great thing if which drugs, besides, like, we don't use pegylated interferon, so which drugs are much more safer during pregnancy, which trimester which drug to use in which trimester, would have taken the presentation to another level. So in general, the presentation was a very good presentation. That's what I want to say, and that's my suggestion. Thank you.
Thank you very much, Dr. Modi. So, Dr. Fekadu, shall we
Okay.
go one by one?
Okay, it was a very nice comment. Actually, I thought it would be beyond time to include. Otherwise, there are treatment in the special condition for hepatitis B. One of these special condition is like somebody with treatment failure, somebody with renal disease, pregnant ladies, or decompensated cirrhosis. Maybe the treatment is somehow differ. So with the question of pregnancy, you know, if your patient is pregnant and have indication, the indication already we have assessed is like non-pregnant. We have to assess whether the patient has cirrhosis. If the patient doesn't have cirrhosis, whether there is a liver injury, that means ALT more than 40 and high viremic more than 2000 or some other indication, then you treat as non-pregnant. That the drug is TDF. TDF is safe, it's class B. TAF is Still, there is argument. Some says TAC still is safe, but I think these are small studies. But TDF is safe, and if your patient doesn't have indication, if there is no indication that I've mentioned in the previous, then now you assess your patient for possibility of vertical transmission. So you are in the side of the newborn. So in that regard, what's recommended is one thing: the higher the viral load, the higher the risk of vertical transmission. Especially this viral load cut point is some studies have shown that anything more than 200,000 international units per ml is risky one. So irrespective of e antigen status, whether that e antigen negative or positive, is the viral load is more than 2,000. That means even if the mother doesn't need treatment, prophylaxis should be started. When do you start? Usually, the risk of transmission is during labor, majority of the time. So we have to have adequate virus suppression for before she starts laboring. That means at least 1 month prayer is very important. What's recommended is at week of 27 around early third trimester, you have to determine the viral load. If it is more than 200,000, give them TDF. Or in a patient who cannot afford probably viral load, if you have e antigen positive individual, usually they have high viremic load, high viral load in most of the time. So that's a weak recommendation, but you can also try to give a TDF for prophylaxis. The issue of when to stop is also very important. So when to stop is, there is no clear guideline, but most of the time what the recommendation is, some says even immediately after delivery, some says wait for 1 month because pregnancy is immune compromised state and there could be serious after delivery. Some says after 3 months. Anyways, if you discontinue prophylaxis even after delivery, then make sure that reactivation, there is no reactivation. So you need to follow the enzymes every 1 month or 1 to 3 months and her clinical condition and so on. Otherwise, you can discontinue immediately after birth or after months or after 3 months and follow once you discontinue. That is the recommendation. The other thing is, if she has viral load, anything less than 200,000, still she can transmit. Even if the chance is not as such high, still she can transmit. So for those individuals, actually the newborn should get immunization. That the immunization is it's a combination of immunoglobulin, that's immediately, and birth dose vaccine. So the child, whether she has high viral load or low viral load, every individual with surface antigen positive, so we have to vaccinate them. The issue of birth dose vaccine is now a current issue. I think pilot study in our country also is completed. I think in the coming year or two, maybe that is come to practice that every newborn who delivered from Hep B should get birth dose. So we don't have steady actually. Then because most now vaccination starts at 6 weeks as EPI program, no study have shown that the prevalence of Hep B between newborn and the date of delivery and within 6 weeks. I don't know that, but the WHO goal is to give this vaccine, birth dose vaccine, in at least 90% of newborn after delivery, immediately within 12 hours of delivery. So that's what we should do, even if we don't have viral load and so on. But if possible, at 7 months or 28 weeks of gestation, try to have viral load. Otherwise, there are some other special conditions, especially renal disease and cirrhosis. Am I clear?
Yeah, Doctor. Yeah, Dr. Moti, thank you for the detailed, brief explanation. So let me present 3 more questions that are raised from participants. One says, can we start TDF for patients with decompensated CLD secondary to HBV without adding viral load? This question is raised by Guta. And the second question is, how effective is the vaccine for HBV, especially for the neonates born from pregnant women with hepatitis? Dr. Tesfaye asked this question. I think, if I'm not mistaken, Dr. Tesfaye is a gynecologist. The third question is, after treatment with that, with TBR, is there any risk of recurrence? The other participant asked this question. So let's
The third question? I didn't get the third question.
After treatment with that,
I didn't get the third question.
the third question says
With
after treatment with that,
treatment with
hepatitis C.
Hepatitis C virus?
Yes.
Okay. All right. Very important questions. So the compensated cirrhosis without having viral load. So this is actually a critical issue. Most of our patients may not afford for viral loading, and any surface antigen positive individual with cirrhosis, whether that's compensated or decompensated, actually a risky one, even if there is a controversy whether if the viral the DNA is not detectable, especially cirrhotic with undetectable DNA, whether to treat or not to treat. What I advise is actually we should start. So having baseline viral load is very important, but if you don't have viral load, if the patient doesn't have HCC and other contraindications, then we have to initiate. HCC is not contraindication actually, but if the HCC is treatable, still we should start on antiviral. Otherwise, having baseline viral load is still needed as a follow-up for your patient. Otherwise, you can start. And the issue of vaccine, how effective? Actually, to have full effective 3 doses are very important, sustainable effect. And how effective is actually we have to determine the antibody towards HBS after 1 month of vaccine. Otherwise, in majority of individuals, especially competent individuals, it's said to be effective more than 85% of the cases. The current vaccine is recently approved, I think in 2017. It's only 2 doses. It's actually more than 92%. It's highly antigenic and highly effective. And after first dose, how much effective? I don't have the figure, but it's said to be very in preventing this newborn from having Hep B. That's what I can say. The third question, what is the recurrence rate after direct antiviral therapy? After that, usually this patient has followed for a long period of time. Once they achieve SVR, actually it is defined as cure. So that was approved with different stages and so on. But reinfection is possible, especially risky individual like having IV drug users, and our setup is not very common. But if the patient has, abnormal behavior, it still can be reinfected because there is no preventive. The antibody is not preventive. The antibody is just it stays in the serum, so that it is not used after for screening such individual. You should not use antibody now. If you are suspecting this could be there could be reinfection, you have to directly go to RNA testing. Otherwise, the drugs are very effective, recurrence is almost negligible, but reinfection is possible. It depends on the risk behavior. So that's why we should counsel our patients. Am I answered or? Hello? Hello?
Hello, Dr. Fekadu.
Yeah. Okay. So that's what I can say, and make sure that everybody should know that Hep C is curable, even if the drugs are very expensive.
Okay, thank you, Doc. Let me add 2 or 3 questions, and
All right.
we will go to winding up our session for today. The first one is, how should we approach, especially for healthcare workers who sustain digestive injury?
Okay.
Yeah, I think this is the question. The second question says, how protective or safe is vaccination after exposure, particularly with newborn, since screening is not common in newborn?
The second one is how common is?
How protective or safe is vaccination after exposure?
Exposure, okay.
Yeah.
All right.
The third question, please, can you comment on the availability of medications and the testing in our country? I have an information that there are dedicated OPDs for hepatitis patients at Adama, Deputy General Hospital, Jijjiga, and Jimma University. So can you comment how is going just bringing the care to the community?
Yes, I think let me start from third one. Yeah. So currently we have a center here in Adama. In the last 3 months or 3 or 4 months, this is in collaboration with the University of Norway, actually, and St. Paul, and the Ministry of Health is also take part. This is one of the big center, actually. We have so far included nearly 700, approach to 700 individuals. So drugs are, the available drugs are actually TDF in our country. TDF is widely available, is as a lone drug. So in the older days, actually TDF was in combination with lamivudine. We could get only from the ART, which is I think illegal to take. This is supposed to be to the ART team, but there are individuals actually like having certificate of HIV without having HIV, but taking the drugs illegally. So it's effective. There is no such drug related toxicity, but TDF alone is available now, where we should not take the combination with lamivudine. There's no added benefits with the combination. Otherwise, TDF is available. I think PAF is also launched it a year ago. The problem is sustainability, but TDF, our center are actually taking, accepting patients from Oromia, different from Afar, from even Somali and Amara region. But Jimma University is also one of the centers already mentioned. So you can use that. Jijjiga is recently started also. And one of the other center is in Afar.
Yeah, the Deputy General Hospital from our.
So yeah, you can use these as the 4 currently active center. St. Paul previously was one of the center, but now St. Paul is not including new patients. So if you have new patients, but you have to make sure that not all individuals start with antiviral. Nearly 1/3 of individuals, like 30% of individuals actually complicate to develop cirrhosis and hepatocellular carcinoma. So these are the individuals that actually needs from drug treatment. So we include these individuals. We assess for any treatment indications, including ultrasound, assessing cirrhosis, and including liver injury, evidence of liver injury, especially with ALT. And we assess. We have the viral load machine. We use the gene expert machine to assess, determine the viral load. So everything is here, but sometimes, due to the current problem in the country, reagent may not be regularly available. Otherwise, we are treating patient with safety. I think the first question is after exposure. So I think one of the things Ministry of Health helping the health profession is everybody should be screened and should take vaccine. So if you complete the vaccine, it is actually protective in adults without any immune compromised issue of immune. Otherwise, it's expected that everybody will mount adequate amount of antibody. But in reality, to say you are adequately vaccinated or not, you have to have measurement of the antibody level after you completed the dose, the three doses of vaccine. Have how much is your antibodies and anti-HBs level? It should be more than 10 million international unit per ml. So that's what the level that is give you the protection. But individual with CKD, HIV, and so on, I think we need to double the vaccine dose. Otherwise, sometimes they may not mount antibody. Otherwise, antibodies, vaccines are protective. But if you are not vaccinated and suddenly have this exposure without vaccination, then maybe immediately depends on actually the route of exposure. But it's good to have surface antigen assessment. If you are negative, then immunoglobulin in the first dose of vaccine is one of the effective way of preventing exposure. With immunoglobulin, you are giving passive antibody, so you are until the vaccine start to work, mount antibody for long-term protection. So that's what I can say. So if there is any exposure, the thing is try to assess for immunoglobulin and vaccination. If the exposure is percutaneous, after 7 days possible. If sexual, after 2 weeks is possible, but the early is the best.
Okay.
Is there any question that? Okay.
Thank you, Dr. Fekadu. I think we are running out of time. Before winding up, I see that there are executive committee members from OPA who are attending the training. So let me give them a chance if they have any comment, any question, any suggestion to forward. And after giving them chance, I will come back to you.
All right.
Okay, Dr. Desani, Dr. Hora, maybe Dr. Gurmessa from OPA office. If you have any comment. Yeah, Dr. Desani raised the issue of time. On behalf of OPA, I promise to arrange another virtual seminars on weekends in the coming few weeks. Okay, Dr. Desali. Dr. Hora.
I think let them to unmute their microphone.
Dr. Gamechu, can you say something?
Okay. So I want to say thank you for all participants to be registered and to attend such an insightful and very nice presentation by Dr. Fekadu. So I'm very happy and glad we had such an amazing senior physicians, and I hope we will continue such seminars and other online trainings, which for other health professionals can also use it. So I want to say thank you, Dr. Guta, also for arranging such very important seminar. And just a few words to say. We will issue certificates. Just we were thinking of issuing just as soon as this seminar ends, but due to some of you couldn't write your full name, we will issue within the coming 24 hours with other documents like guidelines. So thank you all, and others can proceed.
Okay, thank you, Dr. Gamechu, Executive Director of OPA.
Thank you, OPA, and the friends who are working on the stream of CME, as well as Dr. Fekadu, for such an amazing presentation. Hopefully, you will update us on some other topics too. Thank you.
Thank you, Dr. Hora from Adama. Dr. Hora is executive member of OPA. Okay, before winding up, if you want to say something, Dr. Fekadu, let me come back to you.
Hello.
Okay, Dr. Desalegn, are you there?
Yeah, I don't know whether you can hear me or not.
Yeah, we can hear you. We can hear you.
Very good. So I was attentively attending your seminar. It was a really amazing seminar. I thank Dr. Fekadu for his nice presentation. Probably as a comment, one thing I can add is we can increase the number of audiences in the future by arranging the time. I think this is afternoon time. Probably many of the audiences, physicians are on working at hospital. Otherwise, it was really an amazing presentation. Thank you, Dr. Fekadu again.
Thank you.
Thank you, Dr. Desalegn.
Okay.
Okay, Dr. Fekadu, do you have anything to say?
Thank you, OPA and the executive committee to giving me this chance. I'm very happy to be part of that as well. So I'm sure based on the comment from Dr. Hora, I will come with some other important topics that I think is relevant and important to our physician. So thank you very much, OPA, for having me.
Okay, I thank you all. So the certificate will be issued through your email, and we will send you the video through your email also. So the registered participants can get the document through your email. So all of you, thank you very much for attending the presentation, and Dr. Fekadu for presenting this nice seminar. See you another time. Have a good time.
Thank you very much.
so much.
Thank you
so
all.
much.
Thank you very much.
Thank you, Pastor.
Thank you, doctor. Thank you very much.
Thank you very much.
Hello, doctor. Sure.